Good morning, everybody. Thanks for joining us today. I just want to go over a couple of technical slides on how to use the WebEx before we begin. Hopefully you can all hear me loud and clear. If you would like to switch your audio between your phone or your computer, click on the button with the three dots at the bottom of your screen and then select audio, switch audio, and you can flip between the two. Everybody will be muted today to reduce background noise, so we'll be using the chat feature to take any questions or comments. So feel free to type those into the chat throughout the presentation, and make sure your chat is open on the bottom right-hand side of the screen. Click on that chat button, and then the panel will open up. And just be sure to set your chat to everyone so that the panelists can see your question or comment. And with that, I'm going to go ahead and pass it along to Gretchen Brixen from our Los Angeles team to kick us off.
Good morning, everyone. It's so great to have you all. And I see names that are very familiar. I know that we are building up a cohort of individuals that have started to attend the older adult trainings we're having monthly regularly. Appreciate all of you being here. And also the folks that are joining for the first time, welcome. We think we have a really good session, and we hope you will enjoy it. So with that, I'm going to just tell us a little bit about, hold on just a second, let me, I just want to mention just a little bit about CSH and tell you about who we all are. So I think most of you know Corporation for Supportive Housing. We're really all about housing and homelessness, and we are very much care about our older adults that are experiencing homelessness. We do pre-development loans to help create supportive housing, but we also do training, education, consulting, and technical assistance and advocacy. So we are a very kind of well-rounded organization. One thing we care about deeply is racial equity. And we know we've been in a world for 400 years that has created a lot of racial disparities. So as we think about that and the impact on individuals that are experiencing homelessness, we will be trying to bring you along on that journey of creating racial equity. For today, we have our training team. So myself, I'm Gretchen Brixen, the Associate Director of the Los Angeles Office of CSH. Adrian Navarro, who is a consultant and professor at Azusa Pacific University. And then Vanessa, our CSH Senior Program Manager, will be joining us. Most importantly, I wanted to welcome Dr. Emily Thomas. She is with the Department of Health Services, the medical director in their Housing for Health program, with amazing experience, and we look forward to hearing from her. So with that, I'm going to turn it over to Emily, who will start the presentation on addressing the unique health needs of older homeless adults. Emily, thank you for being here, and it's all yours.
Thanks for the introduction, Gretchen, and the CSH team. My name is Emily Thomas. I'm a doctor, a primary care physician. I'm also the Deputy Medical Director of Housing for Health. In honor of the voting season on November 3rd, don't forget to vote. This is me voting in the last election. Today, I'll be talking a little bit more about older homeless adults, chronic conditions, so geriatric conditions that you can find in them. We'll have a little bit of a break. We'll talk about how Housing for Health teaches our case managers about health promotion and accompaniment into primary care. We'll talk about an assessment tool that Housing for Health has developed in order to better match our patients to services and also to the housing level of care. We'll review a case study, and then if we have time, I'll tell you a little bit more about Housing for Health's enriched residential care program. So aging and people experiencing homelessness is an incredibly important topic. I know that most folks who are here on the line know about the complex issues that result in folks not being housed, including poverty, racism, trauma, criminal justice involvement. Issues with mental health and substance use disorders and physical health conditions are all the complex ways that individuals end up on a pathway for homelessness. We also know that people experiencing homelessness have accelerated aging. And so on average, I think about my patients who are experiencing homelessness as being 10 to 20 physiologic years older than their non-homeless peers. So I tend to define older homeless adults at age 50 rather than at age 65. One of my mentors was Margot Kushal at UCSF, and that's the age that she defines it as. I know that oftentimes in the Los Angeles County system, we define older homeless adults as folks who are 55 and older. We also know that the risk of mortality is much higher in people experiencing homelessness. And recently, I've learned that people experiencing homelessness during the COVID pandemic have about a 30% higher risk of, actually we have a 30% higher mortality rate this year as compared to last. So things that I think about frequently in taking care of my patients. I also think about older homeless adults in California and how we have, it's not an emerging crisis. I think that we're already in crisis. The number of older homeless adults has tripled in the last 20 years. Half of older homeless adults are actually experiencing homelessness for the first time in their lives. And the reasons for homelessness may look different than others. It might be precipitated by a health crisis or a personal crisis like divorce or loss of other supportive family members. It's also precipitated by the rising income inequality and increasing rental cost and housing cost, both in all across Southern California. So we know that in California itself, over 40% of people experiencing homelessness are older than the age of 50, and that this will continue to rise as people in the baby boomer generation come to older age, face more income inequality, face more life crises. They're more at risk for becoming homeless than other age groups. So I want to talk about the complex conditions that people experiencing homelessness who are 50 and above face. So I term it a geriatric condition. A geriatric condition is a health condition that's more common in elderly individuals. It's usually not a disease that's caused by a single disease, but it's caused by multiple diseases and conditions. I find that it often goes unrecognized by family, friends, and healthcare providers, and so it's really important that we actively screen for these conditions in our patients. These conditions are important to note because they're associated with higher rates of being hospitalized, of being disabled, and of dying. And know that these conditions aren't diseases in and of themselves, but they tend to be cumulative and interactive. So I wanted to share a couple of flow charts with you, just talking about the complex ways in which physical ailments, psychological ailments, isolation, sensory deprivation all interact to magnify these geriatric conditions and lead to worse health outcomes. So in particular, I think about how age, cognitive impairment, functional impairment, impaired mobility contribute to a complex set of geriatric syndromes that then contribute to frailty and poor health outcomes. Oftentimes, those poor health outcomes and frailty are contributing back to the geriatric syndromes and making them worse. So the key things that I think about are issues related to functional impairment, hearing and visual impairment, cognitive impairment, falls, frailty, depression, urinary incontinence, polypharmacy, meaning taking many medications and maybe having adverse outcomes related to them. Know that our homeless population has a much higher prevalence of geriatric conditions at younger ages. So we tend to think and screen for geriatric conditions in our housed patients starting at age 70. But in our patients experiencing homelessness, I tend to start to think about screening for these conditions at age 50, and I know that the rates are incredibly high. So thinking through any homeless individual who has any elderly homeless individual, so 50 and older with an ADL impairment, is about 40% in some studies. An IADL impairment, closer to 50%. We'll talk a little bit more about falls in people experiencing homelessness, but know that about 1/3 of homeless individuals have had a fall in the last 6 months. And close to 25% of them have some form of cognitive impairment that's the gateway towards dementia. I also like to think about this practically. I was looking for the scientific resources that would help make this point, and they're not there. So know that geriatric conditions make self-care challenging. They often make our clients ineligible for shelters. If you have a client who has urinary incontinence and they're unable to change their adult briefs, they're oftentimes discharged from shelters. And we really don't have a system in place for them. We know that if they're sleeping out on the streets, they are especially unsafe due to their cognitive impairments and other sensory impairments. These are the types of patients who keep me up at night. And it's really critical for us to recognize this when folks are pre-housing, because it helps inform the types of supports that people need to age in place to be successful in the transition to permanent housing. So when I think about geriatric conditions, I think the most important is to recognize and screen for these conditions, to assess them, and then devise a plan that's acceptable to the patient and acknowledges the environment where they live with the interventions that we put into place. And as people who take care of those who are aging, we know that most of the times our goals aren't to provide a cure, but instead we're trying to maintain function, reduce harm, and then really focus on quality of life and those other patient-centered goals. So the first step is just thinking about functional impairment in people experiencing homelessness who are older. So we have our core activities of daily living, whether or not somebody can bathe themselves without support, groom and dress themselves without support, toilet themselves, feed themselves, transfer, so move around in their environment, and whether or not they're able to maintain continence. And I also think about our IADLs, and so I want to make sure that we know that the ADLs are separate from IADLs, but our IADLs are how people are navigating around the world and getting things done for themselves. So are they able to communicate and use the telephone, for example? Are they able to figure out bus lines and transportation from point A to point B? Are they able to prepare meals for themselves as opposed to feeding, which is an activity of daily living, which is, are you able to put food into your mouth to get nutrition? Are your clients able to shop for themselves or to perform basic housework for themselves? Are they able to manage their medications? And many of my clients, even if they don't have geriatric conditions, aren't able to. And are they able to manage their personal finances? So those are much more nuanced. It's also really critical to think about functional impairment as a scale. So I don't think it's binary, yes or no, but when I think about my patients, I think about whether or not they require assistance with these ADLs and IADLs, and what level of assistance do they need? Is it sometimes they'll need assistance, or do they need complete assistance? So those are critical when you're screening for these issues. If we take a look at some of the scientific studies on people experiencing homelessness, this is from a study that was performed in Oakland outside of the Bay Area, taking a look at the number of people experiencing homelessness who have impairments in their activities of daily living. And you can see that about 40% of people experiencing homelessness have 2 or more ADL impairments, and about 50% have 2 or more impairments in their IADLs. I think it's also interesting to note in this same follow-up study of a cohort of individuals who are homeless in Oakland, who we assessed for their ADL and IDL impairments at the beginning of the study, the researchers were able to look at the functional trajectories of these folks over time. So they're interviewing them over the course of 36 months, so 3 years. And we found that some people definitely have some improvement. So if you take a look at the red line here, then you'll see that some folks have improvement and are able to regain some of their functional status. Most people have some sort of persistent impairment. And so if they started out with 2 or more impairments, they tend to remain having functional impairment. We have this blue line, so people who have minimal impairment tend to stay that way as well. And then if you see this green line, this is less of the population, but certainly the top population that I'd be most concerned about is people experiencing continued functional decline over this 3-year period. So know that functional impairment isn't black or white. People can improve, people can worsen, and so it's dynamic over time. And it's important to apply interventions to both slow down the decline in function, but then also to try to improve it as well. The key interventions that I think about, so for mobility and transfers, I think about physical therapy. Oftentimes incredibly challenging when you have people who are living in shelters and on the street, because it's really challenging to maintain the types of physical activity and rehabilitation efforts when you're in these settings. Occupational therapy is more interesting because it tends to be more flexible and environmental. So when I think about occupational therapy interventions, I think about the OT specialist being really sensitive to the environment and context in which one of your client lives. In fact, USC's street medicine team has an occupational therapist on staff who does a lot of interventions for people living in the street. Critically, think about the assistive devices that your clients might need. So for mobility, they might need a walker, a wheelchair, or a cane. Those are really critical interventions to apply to people who are unhoused. Think about how their environment and their setting might modify what type of mobility device would be chosen for this person. Know that when you're coming into the primary care context and you're with your patient who's living in a shelter that might not have access, for example, to a wheelchair accessible setting, how that might modify whether or not that person might be better off with a cane or a walker, or how in many conditions having access to a wheelchair might be safer for them. So be the advocate and help share with the primary care doctors what makes sense in this person's life. Many of the other supportive devices on this list are dependent on somebody having access to a home that they can modify. So does this person have a shower chair to help them be stable when they're showering and not slipping? Are you able to apply handlebars to people's units if they're living in permanent supportive housing? Thinking about toilet seat risers so that people who are frail and not able to sit down themselves are able to have a little bit of a lift there. I like medication organizers and things like bubble packs for all of my patients who have IEDL impairments and are maybe not able to see their medications or read the labels very well, or they're not able to really stay organized, and so these are ways to help them keep track of the medications that they have taken. Critically, for many of our patients, adult briefs are really important to maintaining continence, as are glasses and hearing aids. So even if you have somebody who's living on the streets and in shelters, it's still imperative to get routine optometry and audiology visits so we can make sure that if they have these sensory impairments and they're on the decline, we're able to proactively and quickly add support for them. For me, functional impairment, I think about how I can involve the case managers in a plan of care, particularly related to IEDL support. So if my patient needs assistance with transportation, getting access in line, I'm always reaching out to their case managers to help support that process. The next thing to think about is caregiver support. So when people are making the transition from a shelter or living on the streets into permanent supportive housing, think about how you can get folks into expedited IHSS programs so that once they get into their homes, they have a caregiver who can be there accompanying them across the threshold and ensuring that they're able to meet all of these multiple dimensions of function. If you're lucky enough to have a good PACE program in place and connect people to that, that provides comprehensive wraparound support, and oftentimes these programs are more connected with primary care providers who understand the challenges that your patients will face. And then I also have these insurance-based support services. So LA Care has a fabulous program. Oftentimes these are dependent on your clients having utilized emergency room services or been hospitalized. But I find that the sad consequence of being an older homeless adult is that oftentimes you're ending up at your institution of last resort. You're in that emergency room when you're falling. You're being hospitalized for longer periods of time because you really don't have an adequate discharge plan to be able to support that person. And so oftentimes people will meet the qualifying criteria for these intensive case management programs just by default. The final thing that I think about with functional impairment, in particular, if I have patients with multiple activities of daily living that they cannot meet on their own, is thinking about a higher level of care for them. So whether or not a nursing facility or assisted living facility is the most appropriate placement for them rather than permanent supportive housing, because perhaps in permanent supportive housing, they can't get the level of IHSS support that they would need. So I think about Housing for Health's enriched residential care program. Department of Mental Health has one as well. I also think about the assisted living waiver program, knowing and acknowledging that it has year-long plus waits for people who are applying from the community setting. But if people are hospitalized, also knowing that there's some tips and tricks about getting people into these programs faster. So oftentimes the wait list to go into the assisted living waiver program from an inpatient setting is closer to 3 to 6 months as opposed to that year plus waiting period from a community setting. The next major geriatric condition that I want to talk about is falls and frailty in older adults. So we know that 1/3 of older adults fall every year, so this is all comers. And that falls actually in people who are 75 and older are the most common cause of hospitalizations and injury-related deaths. And they're much more common in my patient population who's homeless due to balance issues, mobility impairments, the environment in which they live, also co-occurring substance use disorders and other types of cognitive and sensory impairments factor in, and so we'll talk about this in the case study at the end of the presentation. So when I have people come into my clinic and when I'm teaching up our clinical workforce at Housing for Health, I like to teach them 3 screening questions which have pretty good predictability as to whether or not somebody's going to fall in the future. They're really simple. Have you fallen in the last year? Do you feel unsteady when standing or walking? And are you worried about falling? And if people screen positive to any of those things, then typically as a primary care doctor, I'm going to do a more comprehensive assessment called the time up and go or the TUG test. When I do this assessment, I ask my patient to sit in a chair and stand without pushing on their legs to stand up, walk for 10 feet, turn around, and walk back to their chair. That should typically take 10 seconds. And so I'm able to time it and then just see if people have any difficulties with actually navigating, so standing, walking, if they're imbalanced, or if they take longer than that timed threshold, then that gives me a fairly good sense that I should think about interventions to prevent falls for my clients. If my patients are going into recuperative care or to an interim housing setting, then oftentimes I'll try to come up with a fall prevention plan with that setting, just like I would do in the hospital setting. And we know falls are preventable. Falls have really They have consequences, so we shouldn't just take this as something as, oh, they're elderly and this is inevitable. There are many things that we can do to prevent the adverse outcomes from falling. So as a primary care doctor, I'd want to review my patient's medical conditions and think about what might be predisposing them to falling. So if they have chronic joint pain and their knee is giving out, well, how can I address that for them to actually reduce the level of falls that they have? If they have issues related to sensory impairments, and I think about how to improve their ability to move in the world, and so if they have issues related to sensing, then actually working with physical therapy can be helpful for gait training. If they have a history of a stroke, for example, then I might apply physical therapy to help with rehabilitating that side that might be weaker. And if they have alcohol use disorder, then I'm oftentimes engaging in a cost-benefit conversation with my clients about continuing alcohol use. I'm also going to review the medications that they're taking because, truth be told, oftentimes doctors are the worst friend to patients when it comes to overprescribing. So if I have patients who are on water pills or diuretics or blood pressure medications or sedating medications, I'm going to think about whether or not it's worth it to keep my patients on these medications, and I can prescribe an alternative medication if they're falling. Because we know that these medications might make people blood pressure lower, make them woozy, make them less sort of responsive to their environment. And in particular, for people experiencing homelessness, I wouldn't want to put them in a position where the meds are causing this risk to increase. I also think about physical therapy, as we said before, always a best friend if you can get your patient in to see the physical therapist. The mobility devices that my patients need. If my patient's living in permanent supportive housing and I'm lucky enough to be able to get a home safety evaluation or home PT evaluation, I'll do it. I talk a lot about life alert buttons for patients who are predisposed to falls because I want to make sure that they're able to contact somebody if they have a fall and can't get up. And then finally, I oftentimes think about the nutritional status of my patients, making sure that they have access to food programs, for example, to ensure that they're able to just support their muscle mass, but then if need be, sending them to a nutritionist to think more about this. The final geriatric condition that we're going to talk about today is cognitive impairment. So cognitive impairment is somewhere in between normal aging and dementia. So my folks who have cognitive impairment might never progress into full-scale dementia. And there's a question as to whether or not it's just going to be normal age-related decline. Cognitive impairment, however, is more about having memory loss and cognitive issues that don't have real functional impacts at this time. And rates of cognitive impairment, so the idea that you're forgetful about things, that you're less able to make executive decisions for yourself and navigate the world, these rates are about 3 times higher in older homeless adults than in non-homeless adults, so in house folks. Also know that dementia, so think about the types of dementia. Cognitive impairment might be an early sign of Alzheimer's disease or frontotemporal dementia, other vascular dementia where you've had multiple strokes. And so subtle changes in people's cognition can be the first marker for dementia, which is why it's so important to recognize this early and start to apply interventions. So the screening that I like to do and that many of you guys might have experience doing is just thinking about alert and orientation status. I add on something, so I do a mini Cog. A mini Cog is a screening test for cognitive impairment, and I'll ask people if they can tell me their full name, where they are, and what the date is. And I always preface this with, these are really silly questions, but I hope it's okay if I ask you. And then I ask them to draw a clock face that reads 10 minutes after 11 o'clock. And if a person is not able to answer any of the alert and orientation questions, then I'm a little bit suspicious about cognitive impairment. But if they have an abnormal clock drawing and I add that on to the orientation questions, then I'm going to start to suspect dementia. If I have an abnormal alert and orientation and an abnormal clock drawing, then I'm going to further screen, and I'm going to do something like a cognitive assessment, like a MoCA, so a Montreal Cognitive Assessment. What I really like about the MoCA is that it looks at different cognitive domains, so visuospatial ability and executive functioning, naming, fluency, and so it looks at those different domains, so I'm able to screen for particular areas of brain dysfunction or organic dysfunction. And so I'm getting a better sense of like, what is the thing that might be impaired in this person? It also gives me a composite score. So I tend to think that anybody who has a 26 or lower on their MoCA has cognitive impairment. I'm oftentimes, however, in homeless adults, because of issues related to literacy, I tend to be a little bit more lenient with these scores. And so I think about people having an abnormal score range with 24 or less. Finally, many of the things that I'll do once I identify cognitive impairment is that I try to address medical conditions that are easily reversible that might be contributing to it. So depression, for example, causes a pseudo-dementia state. So somebody can look like they have cognitive impairment, but it's really just unaddressed dementia. People can have hearing or seeing impairment that can both cause cognitive impairment and make it worse over time. So I'll definitely address those issues with them as well. I think about how social isolation comes into play, about how active substance use or substance withdrawal can factor in. I screen people for HIV, for syphilis, for thyroid disorders, and take a look at their medications to see if anything is making this worse. If I'm worried that their cognitive impairment actually has functional debility, then I'll start to think about whether or not this individual has dementia. And there are some medications that can slow the progression of dementia, like donepezil and memantine. And so if somebody tolerates those medications, then we'll start to advance a trial, oftentimes in consultation with neurology. Thinking about getting an MRI for people, particularly if they have presentations of cognitive impairment and dementia that's unusual. And then again, working with case management, working with physical therapists to really put in place supportive devices, making sure that those supportive devices and case management services are sensitive to where my patient is in the homeless continuum. And then thinking about whether or not it's really safe for my patient to go into permanent supportive housing, or whether or not he or she needs to be in a higher level of care with supervision for their cognitive impairment and caregivers to support to help them with the functional decline that comes often with early dementia and later dementia too. And then these are the two areas on aging that operate within Los Angeles County, and so just a reminder from some of your other training. And then thinking about the key agencies on aging that you can connect your clients to help them get connected to these supportive services, case management agencies, and even primary care networks that are more capable of taking care of older homeless adults. And so with that, it's about time for a break, but I see that Daniel already has asked us a question, so I'm hoping it's okay if I answer this question before our break. So Daniel asked me, do I think that the mini Cogs should be done in all homeless service settings? Can everyone do it? Yes, everyone can do a mini Cog, a 3-word recall, an alertness and orientation, and a clock drawing for sure. People need to be trained on how to talk through the clock drawing and how to interpret a clock drawing, but it's binary. It's either normal or abnormal, and so we can talk about that for sure. And I tend to think that the mini Cog is helpful because we have a number of patients who have really subtle cognitive impairment that we completely miss, and we don't have enough time to do a full MoCA or mini mental status exam because that might take 10 minutes, and your client might not be able to tolerate that 10-minute questionnaire. And so the mini Cog is my short and sweet way to get a sense of where I think they're at. For our break, thank you guys so much for being with us for this first 35-minute period. I want you to think about your specific experiences trying to connect older adults to primary care services. And just think about what things have you tried? When do you think it's important to connect people to primary care? And have you had successful experiences that you can share with us?
Great. Thank you so much, Emily. We will take why don't we take about 3 or 4 minutes? It's 10:38 right now, and let's give everyone 4 minutes, and we'll join back shortly. Thank you very much. Okay, why don't we get started again?
Perfect.
Welcome back, everyone. We'll turn it back over to Emily to carry on.
Thanks for coming back. I didn't know if anybody had some initial thoughts about your experiences connecting older homeless adults into the primary care system. Please feel free to send a chat.
You can put that in the chat, and then we'll unmute you if you'd like to share it.
Great. I'm hoping also that our case study can help explore some of these issues as well.
So Emily, I'm wondering if you could go back to the social isolation model just real quickly.
For sure.
I felt like there was a lot on that slide that, can you just walk us through this real quickly? I feel like with COVID-19, this is such a critical one, but I wasn't able to kind of take it all in.
For sure. So, I think that these arrows are interactive, and I feel like any issue here could actually be connected with another one. But if you take a look at this model, we have a physical element, for example, osteoporosis, a hip fracture, vision impairment and hearing impairment are really critical physical issues that cause often people to stay at home. They have a decreased ability to communicate. I see this oftentimes in my father-in-law, actually. Also think about things that are more psychological or social. So the death of a spouse, a friend, divorce, the loss of children, for example, can then lead into a loss of social interaction and a loss of stimulation of the senses, which then can actually reduce and worsen those sensory impairments. So there's a need for treatment for both physical and psychological issues, can sometimes increase suicide rates. And if we think about it on the other end, if we think about somebody who's doing proactive coping mechanisms related to improving social interactions, then that improves their mental and physical well-being. So social interactions has potentially pros and cons depending on how people are able to modulate their coping response. Also think about social withdrawal and isolation. So when people are withdrawing, we see oftentimes that we'll have concomitant grief reactions, depression. It could also increase and reinforce hallucinations and delusions that people who have underlying serious persistent mental illness have. But also for people who have dementia, sometimes you can have early signs of dementia present with early paranoia delusions, and then even subtle hallucinations. And so thinking about how social withdrawal actually can increase those psychological phenomenon. Again, that social withdrawal and isolation can increase rates of suicide and in terminal illness. And can, in and of itself, this lack of support from friends can create a reinforcing cycle so that many of these issues tend to actually compound on one another. So that when you have issues related to hallucinations or delusions, for example, you're retreating away from social interactions, and that just causes it to be worse. And so that's why. Any questions about the model, Adria?
I think that's really clear. Thank you so much. Yeah, that makes sense, and it's so nice to see it visually. Some of us are visual learners, so it's. I was just going to comment that Julissa put an interesting comment in the chat, and just thinking about how to incentivize people to get connected to medical care, and so you were very creative here with having some candy ready after missing 3 appointments. She said she was able to use an incentive and get the person connected to a physician. So that's very creative. I like that.
Yeah. I think this to me is in the category of contingency management. So how can we provide behavioral rewards and reinforcement for people to do specific things? And I think that I would respond to contingency management. And so thinking about the small rewards applied over time is a really critical tool often. Thanks, Lisa. Okay. So moving on to some of the key work that Housing for Health does in training our case managers to work with all of our clients across the continuum. So health promotion and accompaniment. So when we think about health promotion, we think about like the basic minimum. So you have a client, you want them to get connected to care, The first thing that you should be thinking about is, does my patient have health insurance? Do they have Medi-Cal? So are they younger than 65? And do they meet the financial and income requirements for it? Or do they have Medicare? Are they older than 65 or have some qualifying disability? So you can make sure that your patient is connected to health insurance by bringing them in person to DPSS and following this link. You can also go online, or you can call DPSS. These are all really painful processes. So sometimes the easiest thing is actually to just get people connected to a clinic and ask the worker at the clinic whether or not one of your clients has pre-existing insurance. Once you have this confirmation that their health insurance has been established, then work to find a primary care provider and schedule a clinic. So CCALAC is a wonderful way to get federally qualified healthcare centers in Los Angeles County to understand what clinics are closest to your clients. And then know that Department of Health Services has a number of ambulatory care clinics. If you have a patient who is DHS impaneled and has a history of homelessness, then we have the STAR clinic down on Skid Row, and we tend to focus on people experiencing homelessness of complex physical health conditions that are both in permanent supportive housing, in shelters, or living on the streets, and we try to apply a more comprehensive model of care. The final thing is that once you've done all of this pre-work, make sure that you have the operations in place. So make sure that somebody has access to transportation so that they're able to get to their appointment. And oftentimes, accompaniment is the single most important way to get your patient from point A to point B. And so I'm going to just actually share a quote that Dr. Heidi wrote about accompaniment, because I think it speaks to the way that we train about accompaniment. She's our medical director at Housing for Health. Accompaniment, in one sense, is an easy term. You walk with the patient, not behind or in front, lending solidarity, empowering, not enabling. But accompaniment is incredibly difficult because you must walk with patients as they suffer from the violence of poverty, racism, illiteracy, social isolation, and fatalism. These are things that neither you nor your patient can fix, and yet you have to manage them somehow in order to help your patient swallow the pills every day, get to their appointments on time, and renew their Medicaid applications. So the idea of accompaniment is not just that you're there side by side, pulling your patient into the primary care door, but understanding what are the complex challenges, trying to identify what their needs and hopes and desires are, and then walking with them through the threshold. So you're giving them the power to do this work. And so, Julissa, I see what you're doing for your patient, and that to me is an accompaniment. And so thanks for accompanying your patient through the threshold of primary care. So at Housing for Health, we additionally think a little bit about assessment. So we've walked through different assessment tools for functional status, for cognitive impairment, and then also for falls. And the 5x5 I think about as an added way to better understand someone's clinical complexity. So the 5x5, Dr. Heidi adapted from the vulnerability assessment tool, the VAT. It just didn't come out of nowhere. It scores on 5 different domains, so people's physical health, their mental health, their substance use, their life negotiation skills, which we'll talk about in a moment, and then their functional status. And the reason that we look at this scale is that we want it to complement the VI-SPDAT. We know that the VI-SPDAT is a housing prioritization tool, but the 5x5 is looking at clinical vulnerability that's helpful in determining people's level of care or the number of services that people will need wherever they are in our homeless continuum. The other thing that's really helpful about the 5x5 is that it evolves over time, and it's informed not just by the person in a one-on-one conversation, but you can use your observation, your review of the medical records, your review of the case management records, your conversations with this person's primary care doctor, their psychologist, their prior case managers, the shelter operator, to better inform where they fit on these different domains. Oftentimes, particularly with aging populations, our clients might not have the best insight into their own health conditions and vulnerabilities. If they haven't been in medical care for 20 to 30 years, they might not know that they have end-stage HIV. It might be silent. They might not know that they have heart failure. And so by being able to use the 5x5 and bringing in insight from multiple individuals who might know the client better, you're able to better calibrate like how vulnerable they actually are. I don't know if you've had this experience, but we oftentimes have patients who come into the STAR clinic and they have VI SPIDATs of 4, and you're like, this person's like on fire. And you want to better represent that, and so that's when the 5x5 tool comes into play. I also like to think about the 5x5 tool as a way to help discern like what is the level of housing support that this client needs to thrive. So the first domain that is scored in the 5x5 is physical health. And you score the domain of physical health between 1 and 5. 1 meaning that somebody has no impairments, and 5 being that they have such extreme physical health impairments that it's putting their life at risk. 2 means that somebody has a minor or temporary health condition. So if they have, baseline high blood pressure and they're taking their meds, that's a 2 for me. If they have a broken leg, or if they've had some recent surgery and it's going to go away in the future, I oftentimes score that as a 2. If they have a stable medical condition or a chronic medical condition that's being managed, I oftentimes put them as a 3. So diabetes that's well controlled, if they have HIV and they're on their medications and it's well controlled, it's there. And a 4 I tend to put in the bucket of like chronic medical conditions that aren't well controlled, that aren't imminently life-threatening. For mental health, that's domain number 2. Again, you score it from 1 to 5. It's pretty straightforward and similar. 1 means you have no mental health conditions. 5 means that you have extreme symptoms that impair your functioning in the world. So people who are always responding to internal stimuli, who are unable to engage with the world. People who have depression or bipolar disorder that leads to active suicide attempts. And they're feeling suicidal or homicidal at that moment. Between 2 and 4, 2 is you have a mild mental health condition, good coping mechanisms, good engagement and care. 3 is you have moderate mental health conditions. You are noticing it from that person. That person, though, wants to get better. They're engaging in care. 4 is that person has mental health symptoms that disrupt their function. It's going to limit their engagement in care oftentimes. They're doing the social isolation that we were looking at that model around. And then also think about people who've had hospitalizations or 5150s in the last 6 months. So even if they're doing okay, they've had recent psychiatric hospitalizations, I might put them at a 4. Because that's going to show me that they're in decompensation. The next domain is substance use, and I'm sorry that like the formatting of these are not quite all on. So between 1 and 5, so 1 is no substance use or drinking a beer and a glass of wine every now and then, to 5 being severe substance use with no interest in treatment and obvious deterioration in functioning. So these are some of the people that I see strewn out on the streets from time to time. These are the people who are locked up in their apartments and not coming out and seeking care even though they desperately need it, and they're not taking care of their activities of daily living. So those are my 5s. My 2s are people who have mild substance use that doesn't really affect function. They're able to go about their life. They're able to see their primary care doctors. My threes are people with moderate substance use, and they have some level of acknowledgement of how it's impacting them, and they're making active strides. So they're either engaging in harm reduction, in medications for addiction treatment, they're in recovery. For people who are my fours, these are folks who've had a high frequency of substance use that has definitely impacted their functioning, or they don't want to get treatment at all, even though it's had these impairments. Or for somebody who's been within 90 days of recovery, but they're in a high relapse zone. So one of the patients that I saw who had just come out of a psychiatric hospitalization was 2 weeks into cessation of methamphetamine, was worried but optimistic. So I would put him at a 4 versus maybe 3 months earlier when he was actively psychotic and hallucinating to himself at a 5. So life negotiation skills. So the WHO talks about these as really our communication skills, our empathy skills, our ability to navigate the world and to communicate well with others. We find that people who have some level of cognitive impairment or underlying personality disorder, like their life negotiation skills really haven't been honed. So those folks might have excellent communication. So folks who are pretty functional, probably most of the people on the line, I'd put them at a life negotiation skill of 1. And then many of the people that we see, including family members with dementia, might have a life negotiation skill of 5, meaning that they have severe cognitive and communication deficits. They don't cope very well when they get into challenging situations. So I have a client who's currently at a recuperative care setting, and he has a traumatic brain injury, and he has methamphetamine use disorder, as well as some sort of psychotic disorder, either schizoaffective or schizophrenia. And he is honestly, from week to week, somewhere between a 3 and a 5 all of the time. So he'll have moderate issues with communication, and will have a hard time advocating for himself, and will be really repetitive, and I'd put him as a 3. And then other times, he'll actually need a lot of redirection and support. He'll want to call me 5 or 6 or 7 or 8 times a day. He's not able to communicate with the staff at his recuperative care site to really identify what's wrong. And so oftentimes that leads him to have disruptive outbursts with others. So that's where I think about him and his life negotiation skills. And oftentimes those challenges are independent of his substance use and of his mental illness. Functional status, again, scaled between a 1 and a 5. A 1 is no difficulty meeting your basic needs. A 5 is you can't live safely independently, and you need caregiving support and supervision to get by. A 4 is a high difficulty meeting basic needs. You need significant assistance with your IEDLs and EDLs, but you can get by with caregivers with your aging in place. And then a 3 is moderate difficulty. So you might need some assistance with ADLs. You might need a little bit of caregiving support, but otherwise you're pretty good. Most of my clients who live in recuperative care sites are about a 3 with their functional status, which is that they might need some prompting for their IEDLs and ADLs. They might need some prompting to bathe or to groom themselves, but they're still able to do it independently. I'm going to talk through a case study real quickly. So this is Renee. Renee is a 77-year-old Spanish-speaking patient of mine. He was intermittently homeless in the past. He had been housed. Give me 2 seconds, okay? Sorry, home noises. He's intermittently homeless. He's currently living with his cousin in the Mission neighborhood in San Francisco, and I was his primary care doctor. I saw him pretty regularly. He had type 2 diabetes that was poorly controlled when I first met him, but we were able to get him up to a regular frequency of taking his medication, and it became better under control. But he had nerve problems and vision problems because of his diabetes. He also had major depressive disorder. He had had a history of rectal cancer. They had removed part of his rectum, and as a result of both the surgery and of his radiation, he had urinary and fecal incontinence that he wore adult briefs for and was able to manage on his own. He also had chronic neck pain and cervical stenosis, which is a condition when you have degeneration of the bones around your spinal cord, and sometimes you can have compression of the spinal cord from it or the nerve roots that are coming out. So at one of his primary care appointments, he told me that he was having new falls and that he had some hand numbness. He was having a really hard time actually buttoning up his shirt. And I knew that he, in the past, had had problems with his cervical stenosis, but had been stable. And this was a sign to me that it was getting worse. So spinal cord compression is a red flag for any doctor that you need to do something emergently. And so I ordered an urgent MRI, and that MRI showed worsening cervical stenosis and showed some compression of his spinal cord. So when you see that, you oftentimes offer neurosurgery on the spot because you want to make sure that you're relieving that pressure on the spinal cord so that you don't have worsening deficits like Renee was having. When he underwent neurosurgery, his landlord evicted him. You guys may have had clients like this. The hospital was able to discharge him to a nursing facility because he needed support after his surgery. And the nursing facility was in another county. They came up with a discharge plan, which is that they identified a permanent supportive housing site for Renee in this distant county, not in his home. And Renee was pretty stubborn, so despite having several conversations with him in the nursing facility, he decided to come back to the Mission neighborhood in San Francisco and be homeless. The nursing facility set up transportation to a homeless shelter for him, and he declined. So his friend, after this trajectory, brings him into my clinic, and he's smelling of urine, and he doesn't have any of his medications, and he's asking for support at this point. So we're going to do a little bit of practicing with the 5x5 as a team. So if people can think back on our different domains, again, medical, mental health, substance use, life negotiation skills, and functional status, tell me what you think Renee's 5x5 score would be. And then as people are thinking about this, I'm going to answer Alana Rimmerman's question. So how does DHS use the results of the 5x5? Is it used as part of prioritization for DHS housing resources? And this is a really great question. Right now, we have trained all of our multidisciplinary teams, our interim housing sites, our permanent supportive housing case managers, and our case managers in our ERC, so our enriched residential care program with assisted living facilities, to use the 5x5. And we use it more for determining appropriate levels of care for folks. And we would like to use it to help prioritize people into getting housing. But that's a little bit more of a complex conversation because our coordinated entry system determines who gets prioritized for a housing resource. So we use it as a prioritization of intensity of case management services, and then also movement in and out of our care continuum. So for example, if somebody's at a stabilization site, an interim housing site with fewer resources, and that person is scoring higher, so several number of 4s and maybe even a 5 in their medical domain, we might move them into a recuperative care. So we use it as a tool to communicate between our case management and homeless service providers. So does anybody want to chat me with what they think Renee's 5x5 was? Or is? And it's okay if you don't. So I scored Renee at a medical of a 5. because he's post-op. He has lots of medical problems that are going on. He's not taking his medications. And I'm worried about him living on the streets with these medical conditions. He's very depressed at the end of this stay and does not want to take medication for his depression and does not want to see a provider when I first see him. He doesn't use substances, so I score him at a 1. His life negotiation skills I put at a 4. He's able to communicate well for himself, but he's pretty blunted. He needs an advocate to really sort of help follow through on things, and he's looking to me really for all of his help. His functional status is a 4, so he's not able to maintain continence, but he's actually independent at toileting. He just doesn't have the resources or infrastructure to provide it for himself. He's not grooming himself, but he's not completely dependent on caregivers. If he's put in the right environment, he's able to care for himself. And again, I think the important thing that Dr. Heidi always says when she's training up on the 5x5 is that the importance is not the exact score, but you're able to discern from the score whether or not somebody's high acuity or low acuity. So we know that Renee is going to take a lot of support to get back to a stable place. So I develop a plan of care. I refill his medications. I always fill medications at 30 days for people who are living on the street, knowing that medications get lost and stolen. I schedule a nursing visit so that that nurse can help organize the medications, so that maybe even they organize 2 weeks out in advance and then we hold on to the other 2 weeks. I schedule a mental health visit with a counselor, not being really, like Julie said, not being too confident that Renee is going to be able to make it. And then I start a medication called duloxetine, also known as Cymbalta, for his chronic pain and depression. So for my elderly patients in particular, if I can get by with one medication rather than 2 medications for 2 separate problems, I do it. So that's why Cymbalta is a great choice for him. For his substance use, again, he doesn't have active substance use, but he's asking me for a Norco prescription. And I'm really reluctant to give prescriptions of Norco to people who are potentially going to fall or have their medications stolen on the streets. For his life negotiation skills, he has this friend who brought him into clinic, so I'm going to get his phone number. I'm going to ask Renee where he's staying on the streets and where he likes to go during the day, which is McDonald's, right across from the BART station on 24th Street. I report Renee to APS for self-neglect, and I'll talk a little bit more about that. And I referred him to a local shelter, but he declines the shelter. For his functional status, I order a rollator walker. I have it delivered to the clinic, and I have adult briefs that are going to be delivered to the clinic too. And I touch base with my social workers who are going to give him these assistances when he comes in for his nurse visit. So I'll talk everybody through what I do when I think about reporting people to adult protective services, particularly those who are homeless. So this is all of the information from WEDAX in Los Angeles County. You have your elder abuse hotlines. You have a link for mandated reporting, which I am one. If Renee had still been in the nursing facility, I would have reported what happened with the discharge planning to the ombudsperson so that they could take care of this. So just so folks know. Know that you should report people to adult protective services when they are elderly, so 65 and older, even for homeless adults. Or dependent adults, so they have disabilities between the ages of 18 and 64. And you should think about reporting when these adults are unable to meet their own needs or they're victims of abuse, neglect, or exploitation. And I think about self-neglect as a nuanced one, but a real one. And Kathy said it's 62 in LA. Thank you, Kathy. So when I'm going through the WEDAX report, and again, this is not the one that I did in San Francisco. I'm less familiar with the APS process down here. But on the WEBACS report, you can actually identify that your client is homeless, which is really helpful. You can also say whether or not you want to give this report anonymously or not. So if you want to be contacted with the caseworker to give more enriched information, then you should not check this box. You should designate whether or not you're a mandated reporter as well. And you should designate preferences about when you'd like to be contacted and how you'd like to be contacted. It's also really critical to give information about how to contact your client. So when I go through my process, I always talk about who are their contacts. So what are their cell phone numbers or phone numbers of case managers or close social support, knowing that my patient's experiencing homelessness, I'm going to have a really hard time getting in touch with them. And so I try to take down at least one number, if not two. I like to talk about where my client stays, so where they stay on the street, any physical descriptors that I can give about what they look like or how they might be dressed. If they stay in a tent or another structure, I include that information there. If they tend to hang out at other places, so Renee actually tended to start the day at McDonald's and then hang out with friends at McDonald's most of the days, so I would say that information, then give any information about the primary language that my client spoke. In this situation, the case manager actually ended up contacting me to get more information about how to better get in touch with Renee. I mean, we were able to correspond back and forth to come up with a collaborative care plan for him to try to get him into housing. So that was just the status of this situation. When you're also going through this report, it's important to be specific about the types of abuse or neglect that you're reporting on. So for Renee, this was definitely neglect of physical care, of his personal hygiene, of his food, of his clothing, and then neglect of residence. So he was certainly in an unsafe environment. And then I thought that the neglect resulted in medical care, mental suffering, and then health and safety endangerment. And so when I actually made the call to APS, I said that this was an urgent concern. And they were able to come out over the weekend and send in a weekend caseworker to start to problem solve a little bit about what types of housing we could get Renee into quickly, which I promise is a huge feat in San Francisco. If you think Los Angeles is challenging, it's definitely next level in San Francisco. So despite the fact that the APS worker was able to get in touch with me and try to at least problem solve around an initial plan, I tend to not put all my cards into one bucket. So frankly, if I can be honest with everybody on this call, I ended up calling the Institute on Aging to see if they had emergency case management services that they could apply. I ended up contacting the ombudsperson office because I thought it was an inappropriate discharge plan for a highly vulnerable patient. I also contacted the Department of Public Health's homeless outreach team for this client to come and check on the patient. And ultimately, they were the ones who were most successful at moving my client into respite care or recuperative care within the week. And the truth is that Renee, to me, and to everyone else who had tried to do some coordination of care for him, had declined going in to shelter. And the amazing thing was that it was actually through the connectedness of the outreach team that they were able to bring him in, and through the amazing work of the medical providers who were at the respite and their case managers who convinced him to stay, despite the fact that he said over and over and over again that he didn't want to live in a shelter. We were able to fairly quickly get him moved into permanent supportive housing. So by the time I left San Francisco, this patient had been moved from a health crisis into housing, and we were able to set him up with success. So Patty asked me a question. So how do we use self-neglect of residents without suggesting that for most folks, they are not choosing homelessness? So Patty, I can only tell you from my perspective as a primary care provider, the way that I've been taught by gerontologists. So this is where most of my training comes from. I'm not an expert in the APS precedent here. But for people who are 65 and older, like Renee, meaning that he is opting into homelessness but not able to meet his basic needs, that's where I tend to draw the line with calling APS. In some instances, APS are able to respond, and I think it's helpful to know that for Renee's case, he went from being housed to being unhoused very shortly, and it had really significant impacts on his health. I was less successful at contacting APS when this was a chronic issue. So I would say something about Renee's acuteness was helpful to get APS involved early and quickly. I don't know if other people who are on the line from the CSH team have other perspectives or thoughts to add.
I'm going to call on Adria, who has background in elder abuse. Adria, do you have any other thoughts about this, or does it sound consistent with what you know?
Yeah, I think the idea of acuteness is the key thing, is something that's happening that we can see, potential need for urgent change. So I think you're right on with that, Dr. Thomas. Not much I can add there. I was asking Kathy if there's been a change. I do believe the age is 65 and older for APS versus HUD housing, which is 62 and over. But self-neglect is difficult, and I appreciate Patty's question. I think that when we look at our older adults that are homeless, we can probably make a case for that in most situations.
For sure.
I do want to acknowledge that, and it's true, I think, across the state, is that sometimes I think individuals sometimes feel that working with APS is challenging. And so what I'm really resonating with, Emily, is your approach, which is to take multiple tasks and make multiple connections. And you mentioned the Institute on Aging, which is an organization in San Francisco that's very similar to the organizations that we had in our slide in Los Angeles. Plus, they also have a PACE program. And so I really want to just support that there's an example of reaching across the sectors. So you're working with housing, you're working with APS, you're also working with the older adult case management and PACE organization. So kind of no rock unturned. It's a great approach.
I had a quick question about the recuperative care, Emily. Is that, like here, I think of it as maybe a couple of weeks of housing? Is that how it worked up in the Bay Area?
Recuperative care is so interesting, and I think it's really interesting in Los Angeles because the way that I've worked with recuperative care in other settings, it's always been called respite care, or respite shelters or medical shelters, and that's the way that it was sort of envisioned in Boston. That's the way that it was created when I was in Connecticut in training, and then at UCSF as well. And so respite care versus recuperative care was very differently envisioned in Los Angeles. And as part of Department of Health Services, we envision it as a short-term place for people to come after they've had medical or mental health issues to get stabilized, or to provide wound care, or to enable people to be able to visit their medical appointments if they need to follow up on an acute medical issue. We started to expand it to help people become stabilized from chronic medical issues. So if you, for example, you have a patient who's been recently diagnosed with HIV and you want to stabilize them on their antiretroviral medications for the first time, we would move them into respite care in San Francisco and oftentimes here in Los Angeles as well. What's ended up happening is that our interim housing portfolio is kind of at a standstill So as you guys are experiencing, we have long wait times to get into permanent supportive housing from interim housing. And we at DHS, we don't move people from a housing resource into no housing resource. So it often means that our clients who are started off in recuperative care end up staying in recuperative care for months to years, pending that permanent supportive housing resource, because their level of care need might not be consistent with them going to what we call a stabilization site. They just wouldn't thrive in a usual homeless shelter or interim housing site. They really need that enriched support with behavioral support or medical management on site. So we, contrary to San Francisco, where, we would keep people in respite care, and oftentimes we would move people back into homelessness and respite care in San Francisco. Here in Los Angeles, we don't do that. So our lengths of stays are longer. That's different than the way that recuperative cares or respite cares are set up when they're paid primarily by people's insurance. So insurance tends to pay 14 to 30 days on a respite stay or recuperative care. Oftentimes those insurance can help get people into housing, but they don't always guarantee it. So I'm not as familiar with those programs, but I do know that they have shorter length of stays.
And I was just adding some information about locally we have some support from National Health Foundation, which set up some recuperative care resources really designed to help people get out of the hospital and get some extra help for a couple of weeks. But it sounds like it's a little bit different using the same terminology.
It is. You're exactly right. It just depends on who the primary payer is at the site. And then, in thinking about getting people out of hospitals, that's primarily what we use our enriched residential care portfolio to do. So our enriched residential care portfolio is a higher level of supported care. I see Imelda's on the line. She's one of our case managers for our clients who are in ERC. It's a permanent supportive housing program in an assisted living facility setting. Our clients might not be appropriate for independent living because they're unable to care for themselves or they need assistance with their ADLs or supervision, but they don't need skilled nursing care. So Medi-Cal or Medicare aren't going to kick in to pay for it because they don't have that skilled need. So this is also known as custodial care. So at DHS, we found that it's more cost-effective to move people out of the hospital and into our enriched residential care portfolio. Our referrals are typically initiated by DHS social workers in hospitals, and we've tried to prioritize patients with dementia, so not just cognitive impairment, but true dementia, those with traumatic brain injuries, those folks who have medical, mental, substance use disorders, and then also developmental disabilities. And then those folks who've been discharged and evicted repeatedly from other housing settings, but really aren't stable enough to make it on their own in permanent supportive housing. So those are the folks that we tend to move into our ERC programs. So we think about them as the most vulnerable of the vulnerable. Because the payment stream comes from Department of Health Services, we only accept patients internally. So we have some capacity to move folks from permanent supportive housing programs that are independent living into assisted living, and we're able to identify custodial placements of people coming out of DHS hospitals through this program. In our ERC program, of course, it's 24/7 care and supervision. We pay an enhanced rate. So like the assisted living waiver program, we're not just paying the Social Security rate, but we're paying an added rate depending on the needs of the individual client. We also pair it with intensive case management services to maximize benefits for that person and then health supports for that individual in the facility. We also sometimes find that when we move people from the street and into enriched residential care, that they stabilize. They're able to link with their primary care doctor, stabilize on some of their medications. Their medical problems might stabilize. Their functional impairments might lessen through interventions. And actually, we might get them to a place where they would be safe living independently and actually being on that aging in place trajectory. So we're also working on a program to move people from ERC into permanent supportive housing as well. So I just wanted to give people a heads up about this program. That's the end of the presentation. So I'm happy to answer any questions that you might have.
Emily, I'm going to start off with a question I'll ask verbally rather than the chat. I know that your program is associated with the County Los Angeles Department of Health Services program. We have some folks on the line that are not part of the county system. Are the kinds of services that you've just talked about, are those available, like, for instance, a non-county hospital or someone who's coming from outside of your contracted system or contracted clinics? Are some of these services also available?
Those are really great questions. So we accept applications to our interim housing portfolio through the Integrated LAHSA DMH DHS interim housing application from private hospitals. So if you have a client who needs a higher level of care, so they need that added recuperative care support, I would really advocate to the social workers in that hospital to complete that application. I would also caveat it by saying that it takes a couple of days on our end to process so that we can really comb through the medical records and better understand the level of need of those clients. And so if you feel like this is a trajectory that your patient might need, actually advocate that they start this process early, so several days prior to discharge, so that we have time to review the application and determine an appropriate placement. I get worried because oftentimes I'll have medical colleagues who are calling from Harbor, for example, and they're like, I have a client and they need to go into recuperative care and we're discharging them today. And oftentimes that's too late. So if you can set somebody up for success at the front end, that's great.
That's very helpful. And then one other question is that there is work going on to get folks approved for IHSS prior to when they're in Project Room Key or possibly in an interim housing setting before they actually get to a permanent situation. Les has been working on this really actively. I wondered where IHSS fits into your work. Is that something that you refer for? Is it something that's used often? Any light you can shed on in-home supportive services would be great.
Sure. You know, when I was in San Francisco, I could have clients who had 90-day beds at homeless shelters who could have IHSS come into the homeless shelter with them. So I really wish we were in a situation in Los Angeles County where we could apply IHSS services in shelters. We're not there. But what we do have as part of Housing for Health is we do have expedited IHSS access. So all of our interim housing portfolio knows how to work with DPSS to get the applications in place and teed up so that when people get moved into permanent supportive housing, their services can get turned on automatically. The other service that our Housing for Health clients is something called IHCG, so in-home caregiving. And that's for our patients who don't yet have IHSS services approved or are undocumented and won't ever get approved for IHSS. We can use that as a bridge program pending their IHSS approval. So we have those two options, and typically we like to go with a route of expediting IHSS from interim housing once we know that they have a permanent supportive housing location that they can move into.
Great. Okay. Thank you. Others who have questions?
You know, I have no idea, Jane. I think it's so interesting. You know, by default here in Los Angeles, we often say that we won't allow people who have caregiving needs into our homeless shelters. And so by allowing IHSS in, it's saying, well, this person kind of needs caregiving services. So you get in this catch-22 vortex. But it was really, really helpful and impactful for many of my clients who had physical disabilities to help them clean up their place and to do the grooming and bathing that they needed with that minimal touch support. It also means that oftentimes somebody will need to have people come into shelters, which clearly during the COVID times is challenging, but definitely something to think about more broadly down here if we can use a model to bring to Los Angeles. You know, Courtney Miller just asked me if a certificate of completion is going to be emailed to everybody at the end of the webinar.
It's a great question, yeah.
If anyone would like a certificate, we can get you a certificate. So, and also, if for those of you that have been attending these regularly, we'd be glad to issue something that shows your attendance. So that's helpful. I also see that there are a few of you on a call, or actually a number of you, about 20 of you that are new to our program, and I would really encourage you, if you'd like to continue to be part of these older adult training, if you would take a minute and get me your email just by emailing me. I will put that in the chat box. So I think we are at time, and I wanted to also give folks a chance to put any comments about how helpful or any improvements you'd like in the session into the chat box. So if you'll do that, we'd appreciate it. But mostly I just want to really thank Emily for her amazing work on this session and actually all that you're doing to support homeless older adults. It means a lot. We will be recording this session, making it available, and assuming that if anyone else has further questions, looks like you have your email up there so that folks can be in touch with you. So with that, I'll leave the line open for a few minutes for chat comments, and thank you all again for your participation.
Thank you. And thanks, Gretchen, for making this possible. I'm enjoying seeing all of my people popping up on the chat, so thanks everybody for joining today.